Hello, my name is Alexandra, and welcome to the Excel Healthcare Institute NCLEX review. It is a blessing and a pleasure to have you all here. My apologies, Junior's not feeling well tonight. He has a fever, but thank goodness his temperature has gone down, so I was just getting him settled. So tonight we are going to talk about a lot of interesting topics. So first we're going to open up with just 5 quick questions about the topic that we covered last class. Remember, last class we talked about the difference between acute kidney injury and chronic kidney disease. Remember, acute kidney injury, the onset is rapid. Anything about nursing and NCLEX, if it's acute, it's a rapid onset. And remember, acute kidney injury, if you find the cause and treat it, you can reverse the kidney injury. Chronic kidney disease is non-reversible. If you can remember that, I'm very sure that you can get any AKI versus CKD question correct. Acute kidney injury is reversible. Chronic kidney disease is not. So let's do some questions to see if you remember what we talked about last class. So if this is your first class, don't worry, this is a review and you're going to stay in the class with me until we circle back to these diseases and you get this full lesson. So let's do questions about chronic kidney disease. A client with chronic renal failure is receiving hemodialysis 3 times a week. In order to protect the fistula, the nurse should take the blood pressure in the arm with the fistula, report the loss of a thrill or bruit on the arm with the fistula, auscultate for a thrill and palpate for a bruit on the arm with the fistula, start a second IV in the arm with the fistula. A client with chronic renal failure is receiving hemodialysis 3 times a week. In order to protect the fistula, the nurse should
Three.
Okay, so we've got a couple of 3s. Any other answers?
3.
So 3 is not the correct answer.
Two.
Okay, so you guys should be a little more sure about this, especially because we just covered this last week. Oh, we got some new people. Okay, so why did I say the answer is not 3? Someone tell me.
Hello?
Why is 3 wrong?
It's A, B, and PT.
Yes. And thank you, Miss Stefani. I just saw your messages. God bless you. Thank you. Yes, very good. So remember, when we're talking about, so write this down if you weren't here last class. When we're talking about AV fistulas and AV grafts. Oh, hold on. We got someone trying to get in. Hold on a second. Hold on, let me let them in. Okay, so remember when we're talking about AV fistulas and AV grafts, remember you have to remember ABPT. What does that stand for? ABPT. ABPT means you auscultate, bruit, and you palpate the thrill. Remember we learned that last class? So remember, when you have a patient on hemodialysis and they have an AV fistula or an AV graft, the way that you assess it is called ABPT. You auscultate the bruit and you palpate the thrill. That means when you put your stethoscope over an AV fistula, you hear or auscultate the bruit. It's a turbulent blood flow like a whoosh, whoosh, whoosh. You will hear with your stethoscope, and you palpate the throat. You put your fingers over the AV fistula, and you're going to feel the turbulent blood flow, like whooshing it, like like pulsing under your finger. So 3 is not the correct answer. What is the correct answer, guys? Come on. For 79. Can you say that again?
Blue.
Very good. Thank you. Guys, when in doubt, stick with your core instinct, right? If all of a sudden something loses function, that's not good. So if all of a sudden you can't feel a pulse, so if they say that you report the loss of thrill and bruit, that means the pulse is gone. There's no more blood flow through that fistula. Do you see what I'm saying? Okay, so let's do another question. Number 80, a client with chronic renal failure who receives hemodialysis 3 times a week is experiencing severe nausea. What should the nurse advise the client to do to manage nausea? Select all that apply.
Number 4, number 5.
8 frequent amounts. More frequent.
Okay, so we've got a 4, we've got a 5. Anyone else? And I would like everyone to participate because that way I can see how I can help you better. Don't be afraid. This is how we learn. So everyone should be able to unmute themselves. So 4 and 5. There's one more.
Is it limited activity?
No. This one is a tricky one. This one is a very
5.
tricky one. So 4 and 5 are correct, yes? And there's one more.
Osculate.
Number 2. Okay, so the correct answer, and remember this is a hemodialysis patient. Okay, so let's read the rationale. To manage nausea, the nurse can advise the client to drink limited amount of fluid only when thirsty. Eat food before drinking fluids to alleviate dry mouth. Encourage strict follow-up for blood work. Smaller, more frequent meals may help to reduce nausea and facilitate medication taking. The client should be as active as possible to avoid immobilization. Okay. The client should also maintain the dialysis schedule because the dialysis will remove waste that can contribute to nausea. So remember, guys, so write this down. A patient who needs dialysis, if they miss the dialysis, they get very nauseous. They get very sick because the dialysis is supposed to remove the waste from the blood. So without it, the patient becomes very sick and nauseous. Okay, so these are tips on how a patient who receives dialysis can reduce nausea. So please write those 3 tips down. All right, guys. Next up is 81. So you should remember this answer. You should know this answer. The dialysis solution is warmed before use in the peritoneal dialysis, primarily to, is it to encourage the removal of serum urea, force potassium back into the cells, add extra warmth to the body, or promote abdominal muscle relaxation?
A.
Very good. Perfect, perfect. So remember, we want to warm the dialysis solution in a warmer. Can you warm the dialysis solution in a microwave?
No.
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 So
No.
remember, that's never going to be the answer for your exit or for your NCLEX. Like, you don't use a microwave to do things.
Mommy, look. Mommy.
Yes, Miss Jeanette, I will send that.
Thank you, Miss Alexandra.
You're welcome. Can I
'Cause
send it in the chat?
Yes, please, because I can't see the computer.
Yeah, no
The
problem.
phone is too small for me.
No problem. I just sent it for you.
Thank you kindly.
You're welcome. I say that all the time. Okay. All right. So remember, guys, a lot of the times, like the exit and the NCLEX, they try to trick you by saying, like, can you put a solution in the microwave? The answer will always be no. Okay. You can't warm blood in the microwave, baby formula, dialysis solution. You always want to use, like, for dialysis and blood, like, there's a special warmer for them. Okay. All right, so 82. Which of the following assessments would be most appropriate for the nurse to make while the dialysis solution is dwelling within the client's abdomen? This is a good question.
Two.
Beautiful, beautiful, beautiful. See, this is, I like to call this like true NCLEX question. This is like, for me, a real representation of what you would see on your exit and your NCLEX exam. So why? Why did you choose that answer?
But my eyes went wide to number 4.
Okay, so someone says they feel that they were going to choose number 4.
Yeah. But I know it's 2.
Yes,
It's
okay.
radiation, but yeah.
So like, okay, where's the electrolytes at in the body?
Abdomen.
Where are the electrolytes? Are the electrolytes like in your bone or are they in your blood?
It's not in the fluid, in the blood.
In the blood.
Blood, right? And so we're putting, when somebody is on peritoneal dialysis, because 82 is talking about peritoneal dialysis, right? Because it's talking about the solution dwelling in the client's abdomen. So when we put that fluid in the abdomen, do you think that at that moment it's important like what their potassium level is, or do you think it's more important about their respiratory status, like how they're breathing? Which one is like more important?
Yeah,
How
you
they
said
are breathing.
Yes,
yeah,
they're
it's
breathing. So
because of the water going up, like.
yes. So when that, because there's nothing wrong with wanting to check the client's electrolyte level. There's nothing wrong. But you have to think as a nurse, what is more important at this point in time? Okay. So
Yeah.
let me show you a picture so that I could help you to remember. So what happens when we put fluid in the abdomen?
That is
What are we doing to the intra-abdominal pressure?
Increase it.
We're increasing it. So let me show you a picture, and the words are a little blurry, but I love this picture. So remember, you have your thoracic cavity and then you have your abdominal cavity. So what separates the thoracic cavity from the abdominal cavity?
The diaphragm.
the diaphragm, okay? So the diaphragm is like a dome-shaped muscle. And then so as we fill the abdominal cavity with fluid, we increase the intra-abdominal pressure. Okay, and that increase in intra-abdominal pressure is going to cause the diaphragm to push up, and it's going to make the lungs have less room to expand. So the more the abdomen fills, the less room we have to breathe. That's why like pregnant women are always short of breath, right? So just thinking of that, that would help you to get that question right. So let's go, I think. Let's go. I think we have one more question to do, and then we'll get started with lecture. Oh, actually, because I have to show you something, and then we'll get started with lecture. Okay, 83. During the client's dialysis, the nurse observes that the solution draining from the abdomen is consistently blood tinged. The client has a permanent peritoneal catheter in place. The nurse should interpret that the bleeding, what would you choose?
A.
Okay.
Wait, what?
Someone said
No,
A.
it's B. I mean, it's 2.
Plus.
Number 2.
Very good. Very, very excellent. The correct answer is number 2. Excellent. So
Sorry, I would have won.
it's all right. So this is what we call a critical thinking question because we didn't really cover this, okay? But it's very good if you're able to pick up the answer. So peritoneal dialysis, they have the catheter in their belly that we use to put fluid in. We let the fluid sit for the dwell time, then we drain the fluid out. For the new students, this is a review question, okay? Now, when the fluid comes out, if it has a little blood in it, that could mean one of the blood vessels are damaged in the abdomen, and you would alert the healthcare provider immediately. Okay? Now, let's go to the next part of our lesson. I want to show you all something.
Yeah.
One moment. Okay, so when we're done tonight with class, everyone is going to get these links. So the first link is to the study guide. So I already emailed that to Miss Pauline, Miss Licini, and Miss Frislane. So you're going to see, you three already emailed it to you, but for everyone else, I'm going to put it in the WhatsApp group. So you're going to see the study guide. This is what we use each week to learn from, okay? So when I say like, okay, so next week we're going to do this system and that's module blank, make sure you read that before you come to class because then you'll get more out of class, okay? Then this is the link to the flashcards. So for every system, I've made flashcards on Quizlet.com. Please feel free to use them. You can share them with your friends. You can print them out. And then this is the link to the, you're welcome, Miss Pauline. And this is the link to Google Classroom. This is the link to Google Classroom. So this is where I'm going to start putting the recordings. I used to do it before, but I stopped and I would just send the recordings on WhatsApp. But I'll put them in one place like as we do them. So, okay, so that's the study guide. So now the flashcards, you just click on the link and it will open and you're going to see something that says request to join class. It doesn't show it here, but on your screen it will say request to join class. So just press that and then send me a text message or a WhatsApp message and then I will accept you into the class. Then you will see, so we have flashcards for military time, NCLEX isolation precautions, mental health, peds, maternity, adult, all the systems, musculoskeletal, endocrine, immune, hem, onc, GI, renal, respiratory neuro. So I want for homework that you go through the neuro flashcards, okay? We have on all the EKGs you have to know for NCLEX, adult cardiac, that's where you'll find all your meds, peri-op, adult skin, ear, eye. We have all the positions, like the important positions you need to know for NCLEX, like, you know, Fowlers, semi-Fowlers, your cranial nerves. Please do that for homework. So for homework, you need to do neuro and cranial nerves because you have to know your cranial nerves. Because as a nurse, you're responsible for learning how to assess them. Okay, so these are things that you can just do every day really quickly so that you can be comfortable with these things. The heart blood flow, NCLEX dosage calculation. So these are going to help you with your units, all your lab levels, your electrolyte levels, acid base. So everything you need is there. All right, so now let's go ahead and jump into lecture. So today we're going to be in module 4, okay? And I'm using a different PDF viewer, so it's a little weird. Okay. So module 4, when you open the study guide that I, emailed you or was sent to WhatsApp, it says page 115 at the top. So the beginning of each module has something called the topics covered. So these are the important things. If you can answer these questions or if you can talk about these things, then you know the subject well and you're ready for the NCLEX. So module 4 is adult neuro, adult eye and ear, adult skin, and adult perioperative. So module 4 is a big module, and this is the beginning of adult med-surg. The NCLEX is mostly med-surg. You have to be strong in these systems. You have to be strong in the symptoms of the diseases and the medications used to treat them. As a nurse, it is your responsibility to treat the symptoms of a patient. It's the job of the doctor to identify and treat the disease. As a nurse, you treat the symptoms. So you have to know the symptoms of the disease and what to do for them. You have to know the treatments, and then you have to know what to watch for as you're treating the disease. Okay, so for homework, you have to read module 4, minimum the neuro section. Okay, module 4, it's kind of long because it has like the 4 systems in it, but minimum, I want you to read adult neuro, and then I want you to do adult neuro flashcards and the cranial nerve flashcards. Okay, so we're going to start on page 118. All right, so first up, we're going to learn about the different parts of the brain. So you have the cerebrum, the cerebellum, and the brainstem. Okay, so make sure you know that the cerebrum is made up of 4 lobes. Write that down. The cerebrum is made up of 4 lobes. The frontal, the temporal, parietal, and occipital. The frontal lobe, use this picture as you study. The frontal lobe is for thinking, memory, and movement. Parietal controls language and touch. Temporal, this part of the brain, if you were to look at it from the outside, is by your ears. The temporal lobe is responsible for hearing. The occipital lobe is responsible for vision. There are 4 lobes to the cerebrum: frontal, parietal, temporal, occipital. Underneath the cerebrum sits the cerebellum. The cerebellum is responsible for balance and coordination. Underneath the brain, you have the brainstem. The brainstem is extremely important. There you will find the medulla oblongata, which we're going to talk about in just a little bit. The medulla oblongata, you must know that before you take the NCLEX. So this picture also can help you as you're studying. You have cerebrum, cerebellum, and brainstem. And make sure you know the 4 lobes of the cerebrum and what they're responsible for. Another very important part of the brain is called the hypothalamus, okay? So the hypothalamus, we're going to learn more about that when we get to endocrine, okay? For now, I just want you to know that the hypothalamus regulates hormones. Hypothalamus, hormones. So that's going to be module 8. Okay. I do want you to memorize this. In the brainstem, you have the midbrain, the pons, and the medulla oblongata. The medulla oblongata controls your heart rate and your breathing. Okay, so it's in the brainstem. So this explains why. Okay, I want you to tell me actually. I just told you the medulla oblongata is part of the brainstem, which is purple in this picture. And I just told you that the medulla oblongata controls your heart rate and your breathing. Can you explain to me why, when somebody's in a motor vehicle accident, that the higher up the neck injury is, the more likely it is to be fatal? Can you explain why?
Because because of the heart rate, it might make the heart rate increase the heart rate.
So you're close. So the higher up, so touch your neck and I want you to move up towards your brainstem. The higher up a neck injury, the closer or more likely it is to
Or your
damage.
brain. I see.
Very good, very good. So the higher up a neck injury, the more likely it is to damage the medulla oblongata, correct?
Yeah.
And if the medulla oblongata controls your heart rate and breathing and it gets damaged, is it safe to say that the higher up the neck injury, the more likely it is to affect the patient's ability to breathe on their own? Does that make sense?
Mm-hmm.
Yes, so that's why the higher up a neck injury, the more likely it is to be fatal, because the more likely it is to damage the medulla oblongata, and then the patient's heart rate and breathing are no longer regulated. Okay.
It makes sense. That's why you do karate pulse in your neck.
No, that's just where the carotids are the 2 arteries. You have the internal carotid and you have external. But now the internal carotids, that is what delivers blood to your brain. So that does deal with neuro. So good job. Very good job. All right, guys, so now we're going to learn about the spinal cord. So the spinal cord, it carries information to and from the brain. So now we're going to switch, hold on a second, and we're going to go to, okay, so give me one moment. So when we're talking about neuro, we just talked about the brain, right? Cerebrum, cerebellum, and brainstem. From the brainstem is going to emerge the spinal cord, okay? So I want you to write this down. The brain and spinal cord make up the central nervous system. All right. The brain and spinal cord make up the central nervous system. So we have brain, spinal cord, and then we have the nerves. I want you to write down that the nerves make up the peripheral nervous system. All right, next important thing we're going to learn about with neuro is that the brain is split up into two halves. You have the right hemisphere and the left hemisphere. And most of you already know that the right side of the brain controls the left side of the body. The left side of the brain controls the right side of the body. It's because there's a crossing of the nerves in the center of the brain. They cross. Okay, we reviewed the different parts of the brain. And here's the different lobes of the cerebrum so that you can see them a little better. Frontal, parietal, temporal, occipital. Then you have the cerebellum, which is also called the mini brain. And then the brainstem, where you have the medulla oblongata. Okay. All right. So remember, we just said that the higher up a neck injury, the more likely it is to be fatal. So the spinal cord that you see here, it's color-coded, but that's not what it looks like in real life, right? So the spinal cord is separated into different regions. So you have your C spine, your T spine, your L spine, and then your S spine. So cervical, thoracic, lumbar, and sacral. Okay, so cervical, that's in your neck. Thoracic, it runs down the back of your chest, like behind your chest. And then lumbar, that's your lower back. Sacral is your tailbone, like where you sit down, your butt. And then coccygeal is the very end of the tailbone. So this is how your spine is classified by location, okay? Your spinal cord is protected by vertebrae, okay? So this is called the vertebral canal. This is where your spinal cord resides and is protected because somebody could get paralyzed if this was like damaged, right? So your vertebra, your vertebrae protect your spinal cord, okay? So the vertebrae have the same name. So these are the cervical vertebrae, and you have C1 to C8, okay? Then these are your thoracic vertebrae, the bones, T1 to T11. Okay, then you have your lumbar vertebrae, your sacral vertebrae, and your coccygeal vertebrae. Injuries at C2 to C3 are usually fatal. So that's very high up, okay? You know, and so injuries from C2 to C3 are usually fatal because they damage the breathing center, leading to respiratory failure. I would know that for your NCLEX. Next up is meninges. And can you guys let me know if the picture is big enough or is it coming out small for you guys?
It's big enough.
Okay, thank you. So next up, I want you to know about your meninges. Guys, please memorize this. I want you to memorize the order of the meninges, and I want you to memorize what the meninges are for. So the meninges, they wrap around your brain and spinal cord. Please memorize that. Your meninges protect your brain and spinal cord. Your meninges protect your brain and spinal cord. What is it called when the meninges become irritated? If you know this, your nursing license is coming in just a few months.
Meningitis.
Oh, thank you.
Meningitis.
Father God, send them the license, Lord. Send them all the license, Lord. Yes, okay. So when the meninges become irritated, either from infection or trauma, this is what we call meningitis. Okay, So you have three meningeal layers. You have three meningeal layers: dura mater, arachnoid, and pia mater. Okay, so when we're talking about from superficial to deep, out to in, it's dura, arachnoid, pia. Okay, what does, so like medical terminology, what does dura mean? When something is durable, durable, what does that mean?
Something that lasts for a while,
Very good. What
Yeah.
about something tough?
something tough and
Yes, very
and it
good.
is durable, like something lasts.
Durable,
Yes.
durable.
Like
And
Yes.
then
Yeah. Like a
what
do
does mater mean or matter?
problem. Problem.
Mother, very good. So dura mater, she's a tough mother. She's very tough. The dura mater does, it feels very tough. And it's a protection. So mother, right? So dura mater is a very tough layer. It's the first layer, in an effort to protect the brain and spinal cord. Everything that your body has, every way in which your body is designed was meant to keep you alive and protect you, so that any type of trauma or insult to the brain would have to pass through your skin, through your cranium, through the periosteum, and then through the three meningeal layers before it could get to your brain. Okay, dura, arachnoid, and pia. And then also medical terminology. So what does this mean? Epidural. Epidural. What does epi mean? EPI. On top of,
Um,
right? So epidural. So when a woman is pregnant and they insert an epidural catheter so she could get the anesthesia, right? That medication is being delivered on top of the dura mater. Okay?
mhm.
So epidural, subdural. So if somebody, like, you work at the nursing home, an elderly patient falls and then they have a brain bleed and they identify the brain bleed as a subdural brain hemorrhage, that what we call is underneath the dura. Okay, and then you have the arachnoid. So the arachnoid is important because underneath the arachnoid, that is where cerebrospinal fluid is located. So if somebody needs to do a lumbar puncture, epidural is not enough, subdural is not enough. They must access the subarachnoid space to get the cerebrospinal fluid. Okay. um, all right. Speaking of cerebrospinal fluid, it's called CSF. So anywhere in nursing you see CSF, they're talking about cerebrospinal fluid. It's there as a protection, and it also brings nutrients and it removes wastes. Okay. So how can the cerebrospinal fluid protect the brain? I don't get that. If that is, I want you to think, okay, if you were to punch the air.
Is it like it keep it moist or something?
no,
Is
like
is a fluid?
Well,
like to not make it like what's that called?
I want you to do this.
Like
Imagine
your
you
hand.
punching
Yeah.
the air. I want you to imagine, throw a punch in the air. And now I want you to imagine if you were underwater and you tried to throw that same punch, would that punch have the same force?
No,
No.
No.
No, because liquid absorbs shock, right? It absorbs
Mm.
energy. So it's like it would absorb the energy of any trauma and it would kind of help to lessen the blow. Okay, so cerebrospinal fluid, it helps to protect the brain and spinal cord, and it also brings nutrients and it removes wastes. It is a protective cushion to the neural structure, and it runs through the subarachnoid space. So just like we said, subarachnoid, underneath.
Miss Alexandra, I have a question. You say it remove waste, right? It
yeah.
waste from the brain? Is that what I mean?
Yeah, because anything that uses energy needs nutrients. And then once those nutrients are finished, you will have the byproduct of waste, carbon dioxide.
Mm-hmm.
You know what I'm saying? So any organ or anything, any living matter that needs energy, okay? In order to get that energy to work, it needs nutrients. And then once those nutrients are used, you're going to have the byproducts, which will be wastes, okay? So there's only 125 to 150 milliliters of fluid, cerebrospinal fluid. Okay, make sure you know that a buildup of cerebrospinal fluid can lead to increased ICP.
Mhm.
I want you to write that down. I want you to memorize that.
I have a question. Is it only on the central nervous system the fluid is? Is
Yes.
that why it's called cerebral? Okay, I get it
So
now.
yeah, it's called cerebrospinal because brain, like medical
Yeah,
terminology, cerebral, brain, spinal,
brain. Yeah. Mm-hmm.
and those are the two components of the central nervous system. So you are correct.
So, ma'am, please, what could lead to the buildup of the CSF?
Very good question. So the cerebrospinal fluid is made in something called the ventricular system in the brain, in the choroid plexus. So I'll show you a picture. And so this is pretty much a picture of it. And so whenever there's a blockage of cerebrospinal fluid, that can lead to increased ICP, or whenever there's damage to the brain, and we're going to talk about that. Whenever there's damage to the brain, let's say somebody gets hit in the head really, really hard, or like they're in a motor vehicle accident, they weren't
Yes.
wearing their seatbelt, and when they hit something, they fly through the front window, through the windshield, and their head hits something. So let's look at a picture of the brain and the skull so I can explain something. Does it look like the brain has a lot of room to move?
No.
No, right? Okay, so let's say like, okay, very embarrassing story. This was so embarrassing, but it was raining the other day and I was trying to get into, I put Junior inside, then I had to run out and go get all my bags and purses out of my car. And on the way into the garage, I was barefoot because once I put Junior inside, I took my shoes off so I could run to the car faster. And as I stepped into the garage, I slipped and I fell and I hit my knee. Oh my gosh. It hurt so bad. Would it be normal if my knee got swollen?
Yeah.
Yeah, that's a natural response to trauma. And all that swelling is, it's excess blood and white blood cells trying to get to the area of damage. That is a normal response. So now, comparing my normal knee to my swollen knee is going to be larger, right?
Yeah.
Mm-hmm.
Yeah, my knee has the room to expand. You know what I'm saying? But look at the brain. You know, come on, cut the guy a break. He has no room to expand when he gets hit or hurt or damaged, and swelling is a natural response to trauma, correct?
Yeah.
Yes.
Yeah, anytime there's trauma in the body, white blood cells and platelets want to rush to that area. So because white blood cells and platelets are in the blood, wherever there's trauma, there's going to be swelling as white blood cells and platelets rush to the area to assess and fight against infection and help to stop bleeding. So when the brain gets damaged and or trauma, happens to the brain and the brain swells, unfortunately it doesn't have much space to go. The cranium, hello, knock your head, knock on your skull. The cranium is solid, rock hard. It's not going to expand. Okay, and so brain swelling can lead to increased ICP. Okay, and increased ICP can lead to herniation of the brain. Okay, so this hole here is called the foramen magnum. It's, you know, the hole where your brainstem exits from the cranium and turns into your spinal cord. So if we do not relieve this brain swelling, the end of the brain is going to herniate out of the foramen magnum, and it's going to lead to immediate death because it's going to press on the medulla oblongata. So what are the causes of increased ICP? It could be a blockage in the ventricular system where cerebrospinal fluid is produced. It's because cerebrospinal fluid is supposed to circulate around your brain and spinal cord and back up and around your brain and spinal cord. So if there's a blockage in any of those areas, it's going to lead to a buildup of fluid, and that can increase ICP. A second common cause of increased ICP is trauma to the brain, a cranial insult. This would cause brain swelling, and this is going to cause increased ICP. And we're going to learn about that today. And we're going to learn why increased ICP can kill the patient. Okay. So very good questions. I love the questions because it shows me that you care. So please think, okay, adult neuro. So now we're going to get into diagnostic tests. So we just reviewed the anatomy. Okay. So next up is the diagnostic test. So X-ray. So X-ray, make sure you know on NCLEX and exit, it's not going to say X-ray. It's going to say radiographic imaging. Okay. Or radiography. X-rays, we use it to see bones. And you can also see where bones have separated or broken, which is called a fracture, or a dislocation where a bone is not in the proper position or location. You can determine the size of bone, suture separation in infants, because when infants are born, they have soft spots so that their skull can get out of the vagina. Also, you can look for erosion, breakdown of bone, calcification, and excess hardening of bones. So it's not recommended for pregnant patients to have X-rays to avoid exposure of the fetus to radiation. Okay. Next up, we're talking about CT scans. So these are vital diagnostic tests for neuro that you have to understand. You have to understand your role as a nurse, okay? So for like the X-ray one that we just learned about, your role as a nurse is if your patient gets an order for an X-ray, you need to make sure that if she's a woman of childbearing age, that she has a negative pregnancy test. So that's why any woman who goes in the emergency room, they're going to ask her to pee in a cup. And they're going to do a urine HCG. I came for chest pain. Why do I have to pee in a cup? Any woman of childbearing age, they're going to want to get a pregnancy test so that if at any time during the hospitalization she needs an X-ray, you can look and see, okay, on this admission, boom, negative urine HCG. Okay, she needs an X-ray. But if you get the order for the X-ray and you don't have the results for the pregnancy test, you can't send her. Call the doctor and get the order if you don't have the order for urine HCG to make sure she's not pregnant. Okay, CT scan. So CT scan, so let's look at the difference in the pictures, right? So X-rays, you just see bone.
What was the
CT
noise?
scan, you can actually see.
Scan is for tissue.
Yes, beautiful. So you're looking at soft flesh. It's used to detect intracranial bleeding, lesions, cerebral edema, which we're going to learn about. That deals with increased ICP. Infarctions like stroke, hydrocephalus, which also deals with increased ICP. Write that down, increased ICP, cerebral edema, hydrocephalus. Okay, we're going to learn about those things. You can also see atrophy, like most of the time in an older patient, like in their 70s, it will say that they have some type of cerebral atrophy, age-related cerebral atrophy. That's usually like normal as we get older, that the brain gets a little smaller, okay? And also you can use a CT scan to look for shifts in brain structures, like when somebody has severe trauma to the brain or a brain bleed, it causes the brain to shift to the other side. So like, let's say there's a brain bleed and it's pushing the brain, they're going to call it like a shift to the left or a shift to the right. Okay. CT can be done with or without contrast. So write that down. I want you to write that statement down. CT can be done with or without contrast. It is your responsibility as a nurse to know which one is being ordered. Okay. All right. So we said CT can be done with or without contrast. So now enter contrast dye. So you have to know everything that we're going to talk about. You have to memorize it and be very comfortable with it before you take your exam. Your responsibilities as a nurse before your patient even gets contrast dye. Please make sure the order is clear. If the doctor just says, oh, CT scan of the chest, with or without contrast, that's your job. You have to clarify. If they didn't write with or without contrast, you need to call them and get the clarification.
Wow.
Because if a patient is not supposed to get contrast dye and they do, that's a problem. Especially if they're pregnant, that can kill the baby. If they have chronic kidney disease or renal problems, that can cause their kidneys to fail. Okay, so before getting contrast dye, you have to check for allergies. Okay, you have to ask the patient, are they allergic to shellfish, iodine, or radio-opaque dye? If they are allergic, you're going to let the doctor know, and they're probably going to order Benadryl and prednisone to prevent an allergic reaction. Or if the risk of like a severe allergic reaction is too high, they might just say, you know what, forget the contrast dye, do it without contrast. Okay. The other important priority I want you to know before they get contrast dye, you have to hold metformin. 24-48. 24-48. 24-48. So you hold it 24 hours before they get the CT scan and 48 hours after.
I'm sorry, is the contract dye only for CT scan?
Yes.
Okay.
And cardiac cath, excuse me.
Okay.
They use it because it highlights certain structures better. So it helps them to like be able to view, like visualize like issues or structures that can help them to diagnose a problem. Okay. After getting contrast dye, make sure you encourage the patient to hydrate well. Okay. Because we need to help to remove that contrast dye from the body. Contrast dye, write this down, contrast dye is very hard on the kidneys. It's very hard on the kidneys. So afterwards, you want your patient to get hydration. Okay. Next up is MRI. MRI is used to identify tissues, tumors, vascular abnormalities. Okay. So let me show you a picture. Hold on a second. So CT scan, you see the pictures in slices. And like, it's like you when you're in the room with the radiologist, if you ever see it, it's like, as they click through, they see it slice by slice by slice by slice. Versus MRI, you can see the whole image. Okay. The MRI is a big magnet. So you can't have any metal in the room. I mean nothing, like not even the clip from your badge. The MRI is a gigantic, super powerful magnet. Anything that is metal will fly, like will be attracted towards the MRI machine and stick to it. So if a patient has a pacemaker and goes in the MRI room, the pacemaker is going to leave their chest. So the MRI, no metal objects can go in the room. No pacemakers, implanted defibrillators, implants, vascular clips, bullets, because some people, like, they have a gunshot wound and then they chose not to remove the bullet, like the surgeon maybe chose it safer for the bullet to stay. So any patient with a history of a gunshot wound and the bullet is inside, they can never have an MRI. Because, like, let's say, God forbid, the bullet is in their brain. If you bring them in the MRI room, well, the bullet's coming out. Okay. MRI, no pregnant woman, because it can increase the temperature of the amniotic fluid and can harm the fetus. So those are some very important diagnostic tests that we just reviewed. So in the reading that you're going to do in the study guide, it talks about all of them, okay? So it talks about x-rays, it talks about CT, and it talks about MRI. So please make sure you read the study guide, okay? Another important thing from the study guide that I want you to memorize are the cranial nerves. So read through them in the study guide and then use your flashcards, okay? All right, guys, you guys are doing amazing. Let's take a 10-minute break, and when we come back, we are going to learn what is a lumbar puncture and what are your responsibilities as a nurse. Thank you.
Thank you.
So for lumbar puncture pre-procedure, the patient needs to empty the bladder because we don't want them to have to pee or get up to have to go pee because they need to lay very still for the whole procedure. Intra-procedure, they're going to be in the lateral recumbent position with their knees flexed. You almost want them to look like a shrimp. Like you want them to fold their body as much as they can into a C, because the more they bring their knees up and their head down, like the better view the healthcare provider will have of their vertebral column. And then post-procedure, they need to keep flat to avoid a headache, monitor their vital signs, and monitor the dressing. So they're going to put a dressing on the site afterwards and just make sure that there's no leakage. If there is, alert the healthcare provider. Okay. And again, this is the position, the lateral recumbent position. All right, now we are going to talk about the 6 P's. So I do want you to memorize the 6 P's. You have to memorize these. Yes, Miss Frislane.
For lumbar puncture, they go to L3, L4, or L4 and 5.
Between L3 and L4.
Okay.
Mommy, I don't need to talk to you. Mommy, I
They go
don't.
in between.
Okay. L3 and L4.
Yeah.
Okay. Thank you.
Like L3 is at the top, L4 is at the bottom. They go in the middle space.
Okay.
Perfect.
L3 and L4. Okay, thank you.
You're welcome. My pleasure. Okay, so now we're going to do the 6 P's. Guys, you have to memorize these, okay? So the 6 P's are part of the neurovascular assessment, okay? So because we're doing neuro, you have to start memorizing these now. We will see these again when we get to musculoskeletal, but these are a foundation of nursing assessment. So these are the 6 things you're going to look for if a patient has had a surgery on an extremity. If they've had any trauma to an extremity, if they have a restraint or a cast on an extremity, you have to check the pulse. You have to assess the pain level. You have to see, is the extremity pale? You have to assess for paresthesia, paralysis, and the polarity. So the pulse. Why do you think it's important to be able to feel a pulse in an extremity that has had trauma to it, or has a cast or a restraint? Why do you think it's important to feel that pulse? Because if you feel a pulse, oh, maybe they can't unmute themselves. Hold on. Okay, everyone should be able to unmute themselves.
For
Sorry.
circulation.
For circulation, beautiful. If you feel, okay, so try to palpate one of your pulses now, like palpate your radial pulse on your wrist really quickly. If you can feel a pulse, that means that blood is getting to that area. That means oxygen is getting to that area. That tissue is going to stay alive. So you always want to feel a pulse, okay? Now, if you don't feel a pulse, we're going to learn something down the line called a Doppler, which can help to locate the pulse. If you still cannot locate the pulse, you notify the healthcare provider. That is a medical emergency. You want to assess the pain level. If the pain is more severe than what you expected for that injury, you would want to alert the healthcare provider. If the extremity is pale or has numbness or tingling, or the patient cannot wiggle or move that extremity, alert the healthcare provider. Also, if it's cold as well. Because remember, we're warm-blooded. Where there's blood, there should be warmth. So where there's like paleness and cold, that means there's no blood getting there. That limb is going to die if we don't try to figure out what's going on. Okay? Please, please, please memorize your neurovascular assessment. All right, so now we're going to get into some important concepts here. I want you to know what is the best indicator of neurological status. That is called level of consciousness. Level of consciousness is the best indicator of neurological status. Please write that down. Because you know it's not fair. It's really not fair because, like, okay, if you want to know how the heart is doing, you just check the pulse and the blood pressure, right? No big deal. If you want to know how the lungs are doing, you just count the respiratory rate. Check the pulse ox. But how can you see how the brain is doing, right? You don't have x-ray vision, so you can't look at it. So how do you know how the brain is doing? Well, you assess the patient's level of consciousness. And I know you're saying, well, how? How can I do that? Because when I was in nursing school, we used the level of consciousness, like we would say the patient was alert or lethargic or stuporous, uptunded, comatose. Remember those?
I remember Orient time doing.
Yes, so that's, yeah, the orientation, yeah. So level of consciousness is how awake is the patient, right? But the problem is like, maybe you think this patient, because remember, it used to be alert, lethargic, stuporous, uptunded, comatose. Here's the problem. I think this patient's just lethargic, but you think they're stuporous. So it was like the lines kept blurring. You know, you think they're stuporous, this nurse thinks they're uptunded. So there was no objectivity when we were describing level of consciousness. So that is why as nurses, we follow the Glasgow Coma scale. So please also memorize this. The Glasgow Coma scale is the most accurate, objective way to describe level of consciousness. Okay? So when you want to assess the brain, you want to first begin with, hey, how conscious is this patient? And the way that you assess their level of consciousness is you are going to determine their Glasgow Coma scale score. And most of the time as nurses, you can do it in 5 seconds walking in the room. Hey, if you walk in the room and the patient turns their head and looks at you, that's half the battle. If you say good morning and they say good morning, there you go.
Mhm.
Right? So most of the time, it doesn't get to the point where you even have to calculate it. Because if they look at you when you walk in the room, if you say hello and they lift their hand and say hello back and talk to you, 15. Give them a score of 15. Don't even waste your time. This is more for people like who have some type of brain injury or maybe got like anesthesia and that, decreases their level of consciousness. All right. So we got to give the patient a Glasgow Coma scale score when their level of consciousness comes into question, right? For you and me, our Glasgow Coma scale scores are going to be what's called a 15. So Glasgow Coma scale goes from 3 to 15. 15 is perfect. They're wide awake, alert, moving, talking. Thank you, Lord. Okay. However, when they get below an 8, that is what we call coma. You have to memorize that. Okay. So please write this down, and then we're going to look at another interesting picture together. All right. So let's look at the Glasgow Coma scale. It's actually a scale. So there's 3 categories you're looking at. You're assessing for Glasgow Coma scale. First up is eye-opening response. Second is best verbal response. Third is motor response. So eye-opening, verbal, motor. So remember I told you if you walk in the room, hey, good morning, Mr. Johnson. If they open their eyes and they look at you, that's half the battle. Good morning, good morning, nurse. There you go. How you feeling today? If they put their hands up and say, well, I don't know, I've been better. Hey, 15. And you didn't even need to look at a paper. Okay, so eye opening. If your patient opens their eyes on their own spontaneously, you give them a 4. If they open their eyes when you speak to them, that's a 3. If they only open their eyes when we kind of induce some type of pain, that is a 2, or no response, like no matter what you do, you could shake them, they don't open their eyes, that's a 1. Notice that the lowest score in each category is a 1, so that's why the Glasgow Coma scale goes from 3 to 15. Okay, best verbal response. So if they're oriented, so there you go, Nurse Stefania. Remember, oriented to person, place, and time, you give them a 5. If they're confused, like to person, place, or time, you give them a 4. If they say inappropriate words, that's a 3. Incomprehensible words, like you can't understand what they're saying, you give them a 2. If there's no verbal response, a 1. Best motor response. If you tell them, squeeze my left hand, and they do it, give them a 6. If they only move when you induce some type of pain, like you apply sternal pressure or nail bed pressure, which you might have to do like in brain trauma patients, 5. Flexion. So if we do like nail bed pressure and they bring their arm close to their body, that's a 4, okay? Now, if they have abnormal flexion, and we're going to learn about that next class, decorticate versus decerebrate. So abnormal flexion would be a 3, abnormal extension would be a 2. You don't have to memorize this. You do not have to memorize it, but you have to be familiar with what it means. Remember, Glasgow Coma scale is the most accurate way to determine the patient's level of consciousness. It goes from a 3 to a 15. 15 is normal. 8 and below is considered coma. So let's do a question together to see if you understand it. Okay. Okay, so I'm going to share my whole desktop with you because the way this question is, I love this question book, by the way. I love this question bank, but this one is like the pictures all the way at the bottom. So I have it showing for you on the side. Can everyone see the question and the chart?
Yes.
Okay, so a 12-year-old child has had a traumatic head injury from playing in a football game. He is admitted to the emergency department and transferred to the pediatric intensive care unit. That's called the PICU. He has an IV of dextrose 5% in water at 21 milliliters per hour and nasal oxygen at 2 liters per minute. The nurse is assessing the child at the beginning of the shift and reviews the Glasgow Coma scale flow sheet below. The nurse notes that the child responds to pain, is making incomprehensible sounds, and has abnormal flexion of the limbs. What should the nurse do first? So before we look at the answer choices, I want you to tell me, what is the patient's Glasgow Coma scale score based off of this assessment? So I'm going to give you a few moments to figure that out, and then we will go through it together.
Ooh.
Gonna be 5. No, 5.
Okay, so someone has said 5. Are there any other answers?
2.
7.
Very good, very good. The correct answer, well, the Glasgow Coma scale score for this patient is 7. So the nurse notes that the child responds to pain. So for eye opening, what score would you give them?
4.
If they respond only to pain?
It is 2, 2.
2.
No,
Very
2.
good. 2, right? Because it says
Eye
eye
opening,
opening
2.
to pain, 2.
Mhm.
Okay, next up is they make incomprehensible sounds. So they kind of skipped
2.
motor and went to verbal. So incomprehensible sounds, what score would you give them?
2.
2.
2.
That's
So
for
far
cat.
we're at 2 and 2, which is 4. And then it says they have abnormal flexion of the limbs. What would you give them for motor response?
3.
3. So that's how we get 7. And what did we just say about Glasgow Coma scale? What does it run to? From what to what?
From 3 to
1 to 15.
From
3 to
3
2 to 15.
from 3 to 15. And so what's the normal score?
8 to 15.
15.
15.
15, very good. And so what does it mean when someone is below an 8?
Coma.
Coma.
Coma. So what's this child's level of consciousness technically?
7.
They're in a coma.
Coma.
Okay. So it says, let me see, what should the nurse do first? Should you notify the healthcare provider, lower
Yes.
the head of the bed, increase the rate of nasal oxygen, increase the rate of the IV infusion?
1.
Very good, very good. You want to notify the healthcare provider. Very good. And then also, I know that we didn't talk about it, but at the bottom of the table, you can kind of see. So this would be like in today's time of NGN, this would be like the exhibit with the different tabs. So I want you to look at this last section here, and I want you to tell me what has happened to this child's level of consciousness throughout the shift.
It going down.
Is going down, right? So because 15 is normal, so when they came in at 5, it's a 13, then 12, then back to 13, then 11, 10, 9. So it shouldn't even have to take 5 hours, for us to have realized something was wrong, okay? So, you could have even, by the time it got to 11, let the doctor know. Waiting until it was a 7, that's very dangerous, okay? All right, so now let us okay, so now let's do this for a patient who has come in with a possible TIA, which we're going to learn about next class, which is a mini stroke. Okay, so a client is being monitored for transient ischemic attacks, mini strokes. The client is oriented, can open the eyes spontaneously, and follows commands. What is the Glasgow Coma scale score?
Sorry, which one?
We're doing this one here.
Okay.
A client, you don't even need the scale. And I want you to tell me the answer and why you don't need the scale. A client is monitored for transient ischemic attacks. The client is oriented, can open the eyes spontaneously, and follows commands. What is the Glasgow Coma scale score?
15.
Ooh, that's my Neuro ICU nurses. Yes, you don't even need the scale because he's normal and everything. What more normal can you be if you're oriented? You open your eyes on your own and you follow command. He's a 15. Very, very good. All right, guys. So now let's just wrap up lecture a little bit and then talk about homework. Let's see. All right. So next up, so now I don't want to give you too much because I don't like overwhelming people. When you're learning this stuff, it's a lot coming at you all at once. But increased ICP. So there's 2 things that I want you to memorize. So you have the Glasgow Coma scale, which is 3 to 15, and then you have ICP, which is 7 to 15. So Glasgow Coma scale is us, quantifying the patient's level of consciousness, right? Intracranial pressure is like the pressure inside the brain or inside the skull, okay? It's the pressure inside the skull. So remember, you have that cerebrospinal fluid circulating around the brain and spinal cord. So anywhere there's fluid is the movement of fluid generates pressure, okay? It exerts pressure. So that's natural. It just has to stay between 7 to 15. And technically it's 7 to 15 in an adult that's laying flat. Don't worry about that. Normal ICP is 7 to 15. So that's the last thing that we're going to talk about today, because The rest, it's gonna get very deep next class. So it's very important that you study everything that we learned today. Your homework. Please, I would like you to access the study guide that I'm going to send to you and read the whole chapter on neuro. You've got 6 days. And I want you to do your flashcards, the adult neuro flashcards and the cranial nerve flashcards. Then when you come back, next class we're going to talk about increased ICP, what to do and what not to do. These things will help save a life. All right, guys, is there any other questions for me before we go?
You're gonna email us the homework pages.
Okay, I can do that. And you know what? And I can show you too. So the homework pages is going to be from, in the study guide, from 115 to, it's going to be from 115 to 132. And then for the flashcards, so you're going to read pages 115 to 132. And then for the flashcards, for adult neuro, oh Lord. I made these flashcards so long ago. So adult neuro is 220 flashcards. And then, Lord, I made these in November 2020. Oh my gosh. And then the cranial nerves is 37. So but the flashcards, you know the way I designed the flashcards, I made them using the study guide. So if you're not a fan of reading, do the flashcards and you'll still get the same content. I'm a flashcard person, and you can even like do the flashcards on your phone. So a lot of my students, when they're at work and they're on break, they like to do the flashcards. So see the way it works. And when you open Quizlet, guys, Quizlet is free. So it's going to try to offer you to upgrade. Just press the X. Okay. So yeah, like the way the flashcards is like, what are the 4 lobes of the cerebral cortex? What's the answer to that, guys? What are the 4 lobes of the cerebral cortex?
Occipital, temporal, frontal, and the occipital, frontal, temporal, and what's the last one?
Starts with a P.
Parental.
Parental.
Yeah. Very good. So see, that's how the flashcards work. It asks you a question, then you click on it, and then frontal, parietal, occipital, temporal. Good. You're done with that one. Then you go to the next one. Okay, so what part of the brain controls breathing?
Brainstream.
Really?
The
Starts
No.
with the M. The medulla oblongata.
I would say
The
Yeah.
medulla oblongata. And I even put pictures. And
yeah, it's brainstream. Okay.
yeah, the medulla oblongata. And you can go like, okay, so you could do the flashcards individually. If you want to see all of the flashcards, you just scroll down and you can see all of them. And then you can print them too, because I like to print stuff, because I like to like hold stuff in my hand and highlight it and stuff. So you go to print and you can do like, you could do it as a table like that, where it's like the answer will be on one side, the question will be on one side, the answer on the other. You can do it like a glossary. And you can choose the size. So, you know, you can do what works for you. You know, maybe if you print it like this and then you hide the answer and you go through and you answer. So that is there for you. So that's the homework. So we'll be back next Wednesday from 9 to 11, and then we're gonna get into we're gonna get deeper into neuro and help to get your license. So thank you so much for spending this time with me. I hope you have a wonderful evening, and I will see you next week, same time, same place. This recording, it takes like a couple hours for it to save. I will post it on the Google Classroom and in the WhatsApp for you. All right, everyone. Thank you so much.
Thank you.
Have a
Good
great
night.
night.
Thank you.